welcome to SureenaSpeaks, and in this video I'm going to go over pregnancy and breastfeeding. Now I have covered these two topics ever so slightly in two of my other videos, one called Guidance on Prescribing, the other called Other Topics, so make sure to check those videos out too for extra information that's included in there. Now, pregnancy as a whole is a big topic, so I've tried to condense this video down into aspects and areas that you might come across whilst you're practicing. So, for example, looking at morning sickness, gestational hypertension and gestational diabetes, as well as giving other hints and tips and advice that would be useful for mums-to-be to have. Now, pregnancy is made up of 3 trimesters, the first, second and third. If medication is given during the first trimester, this is when the baby is most at risk of getting congenital malformations. It's usually during the 3rd to the 11th week that is the highest risk. During the 2nd and the 3rd trimester, if medication is given at this point, this could potentially cause complications with regards to growth and development and can be toxic upon the fetus. Now, when we look at breastfeeding provides many benefits, including building up an immunological response and great nutrition for the baby. But when medication is being given to the mum at this time, there's certain aspects that we need to think of. Firstly, how much of that active metabolite is going to go into the baby? So looking at the pharmacokinetics, the absorption, distribution, elimination. We also need to think about the effect that that's actually going to have on the baby, so the pharmacodynamics. Now, there is some medication that is a big no-no if a woman is breastfeeding. These include fluvastatin, because this is heavily excreted in breast milk and therefore can cause adverse effects to the baby, as well as bromocriptine, because this can affect lactation, and there's also phenobarbital, which can inhibit the suckling reflex. So there's many different medicines out there that should be avoided if a woman is pregnant. Now, a lot of these I cover in my other topics video with a handy mnemonic called Teratoa, so check that out. But as well as those medicines, there's also chlorphenicol, doxycycline, aspirin, which should also be avoided. Aspirin I'm going to talk about in a little bit more detail later on in the video, so we'll pause that one for a moment. Another one which they do like to ask in exams is misoprostol, because misoprostol can induce uterine contractions. It's also associated with abortion and birth defects, so that one is to be avoided in pregnancy. And if we talk about smoking cessation for a while, so say a woman finds out that she's pregnant, but she's also a smoker. This is a classic example of one of those benefit to risk ratios. Now, in general, we don't want a woman to have nicotine, but if she's smoking, then she's better off, based on the benefit to risk ratio, she's better off going with the nicotine patches than she is with continuing smoking. Now let's talk about morning sickness. Now, as a term, morning sickness, it's slightly misleading because actually the woman can get sickness at any point during the day. It's not just the morning. It tends to clear up though, morning sickness, between the 16th to 20th week. But yeah, it's something that can happen throughout the day. It's not just subjected to just the morning time. There is a very severe form of morning sickness where there's lots of nausea and lots of vomiting, and it's known as hyperemesis gravidarum. Probably not pronouncing that right, but let's just go along with it. And that's what Princess Catherine, Kate Middleton, that's what she had, hyperemesis gravidarum, where it's really hard to keep food and drink down and you're just vomiting up loads. Some women have reported to vomit at least 50 times, and it's a very, like I said, it's a very severe form. It can cause dehydration, weight loss, hypotension, so low blood pressure. In cases when we would need to refer our patients is, for example, if you had a woman come to you and she had very dark urine or was passing very little urine, if she had abdominal pain, a high temperature above 38 degrees, or there is any blood in her vomit, all these cases we would need to refer. And women that do have hyperemesis gravidarum, they need to be under specialist care. But if a woman came to you and she was complaining that she's feeling quite nauseous, vomiting associated with her pregnancy, and it wasn't hyperemesis gravidarum, it was a less severe form, just the nausea and vomiting that can be associated with pregnancy, there's plenty of advice that we can give our patients. So, for example, we can advise them to have small but frequent meals throughout the day and not have really stodgy meals. Usually high carbohydrate, low fat foods would be best. So dry toast, crackers, biscuits, this can all help. Fluids, again, small amounts of fluids frequently throughout the day rather than just chugging a big glass during the day. Little fluids, that can really help too. Ginger has helped a lot of women too, so ginger ale, again, ginger biscuits. As well as that, the other advice that you can give to expectant mothers is to avoid smells that can sort of set off that gag reflex. So I know my mum's told me that when she was pregnant with me, she couldn't stand the smell of garlic and onions being cooked. She loved the taste of it, but the actual smell of it, that would set off her sort of gag reflexness. So tell mums to try and avoid those smells that could set that off, and hopefully that would really help. But if they've tried all these things, it hasn't helped, and they're still in despair, then it might be worth them going to their GP and they may prescribe them metoclopramide, but this shouldn't be given at the end of pregnancy. Other conditions that you might end up seeing in pregnancy is, for example, thrush. Now, thrush is really common in pregnancy, and the soft gel pessaries can be used, but without the applicator. They shouldn't be used with the applicator, but they should only be used under the supervision of a midwife or a physician. Other conditions that pregnant women may come to you about are, for example, backaches, swollen ankles, hemorrhoids, constipation. Again, constipation is very common, and if diet and light exercise, any specific types of exercise that pregnant women can do, if that's not helping, then something like lactulose might help them. Now, with regards to food in general, food that they should avoid is, for example, seafood, pate, raw eggs, uncooked raw meat, so no sushi, and caffeine. Now, they don't need to cut out caffeine, they just need to limit their intake to 200 milligrams per day, or less than 200 milligrams per day. So to put that into context, a cup of coffee, instant coffee, is about 100 milligrams of caffeine. A cup of tea is about 75 milligrams. So like I said, 75 milligrams of caffeine. So like I said, they don't need to cut out caffeine, but just limit it to 200 milligrams a day or less. In terms of vitamins, so if a woman is trying to conceive, while she's trying to conceive and up until the 12th week of pregnancy, it's recommended that she takes 400 micrograms of folic acid. This is to prevent neural tube defects such as spina bifida that can occur in the baby, and they should take 10 micrograms of vitamin D throughout their pregnancy. Now, if there's a higher risk of neural tube defects associated with the expectant mother, then they might be recommended to have 5 milligrams of folic acid instead. So this might be if a previous child has had neural tube defects, or if there's a family history of it. Now let's talk about hypertension, and there's two types of hypertension. There's chronic hypertension and gestational hypertension. So chronic hypertension is whereby a person has high blood pressure and then they get pregnant. Gestational hypertension is when they get high blood pressure whilst they're pregnant. So in terms of chronic hypertension, usually their medication, their antihypertensive, will be changed to methyl-dopa, and 2 days after giving birth, the methyl-dopa should be stopped, and if applicable, their original antihypertensive might be then continued. So now with gestational hypertension and preeclampsia, women are at higher risk of getting hypertension during their pregnancy if they have other conditions, for example, diabetes, chronic kidney disease, if they've had a previous pregnancy where they've had preeclampsia, but this isn't always the case, but it puts them more at risk. And if this is the situation, then it is advised for the mother to have aspirin once a day starting from the 12th week of pregnancy, week 12 of pregnancy, up until the baby is born. Now we know though that as pharmacists, especially in a community setting, we can't give out aspirin to anyone under the age of 16, and we can't give out aspirin to a pregnant woman. So if someone who is pregnant does approaches us and asks for aspirin, it's advised that they get a prescription from their doctor, or if you're handed a prescription from a pregnant woman with aspirin on there, that we do get in touch with the doctor just to make sure that this is okay, that they do want them to start with this, they do want them to take this. And again, it's one of those risk to benefit things. And like I said, because aspirin can cause Ray's syndrome, which is why we can't give it in under 16-year-olds. It causes Ray's syndrome in under 16-year-olds. We can't give it to them. and we can't be giving it out to pregnant women either. So if you're pregnant and you're watching this and you have gestational hypertension and your doctor has said it's okay for you to go to the pharmacy and get buy aspirin over the counter, no it's not, because we can't sell it to you. You have to get a prescription for it. So in terms of which medication would be first line in gestational hypertension, firstly it would be labetalol. If that can't be given, then methyl-dopa. If that can't be given, then nifedipine would be considered. So now moving on to diabetes. And diabetes, again, there's two different forms. You can have pre-existing diabetes, so you're a diabetic patient and then you get pregnant, or gestational diabetes. Well, whilst you're pregnant, you then get diabetes. Now, in some women who have gestational diabetes, changes to diet and exercise alone won't help them. And some women who are at higher risk of getting gestational diabetes are, for example, women who have previously had gestational diabetes, those with a BMI above 30 kilogram per meter squared, and those that are of a minority ethnic group where diabetes is prevalent. Now, with pre-existing diabetes, metformin might be the drug of choice with or without insulin. And then once the mother starts breastfeeding, she might then be continued on metformin or changed to glibenclamide. Now, glibenclamide is contraindicated in pregnancy because of the risk of hypoglycemia on the infant. And again, it's one of those benefit to risk ratio situations where you need to look at the benefits of breast milk on the infant versus the benefits of the drug on the mother. So it will really be down to the patient and the prescriber with what medication and what changes to their medication they may have. In terms of gestational diabetes, this again might be given with or without insulin, and again metformin may be given or glibenclamide from week 11 onwards during pregnancy. But again, it's down to the patient and prescriber what they think would be best for the mother, taking into consideration the effect that it could have on the fetus as well. And all medication in terms of gestational diabetes, so if they're taking metformin, if they're taking insulin, if they're taking glibenclamide, that can all be discontinued after birth, so once the baby's popped out. And infections now let's look at. So urinary infections in particular, again, very common in pregnancy. The safe antibiotics that can be given are, for example, amoxicillin, flucloxacillin, nitrofurantoin, but not trimethoprim. And I once had a pregnant woman come with a prescription for trimethoprim, and I had to say, sorry, can't give that to you, contraindicated. But there are alternatives. There are the amoxicillin, the flucloxacillin, and the nitrofurantoin. Those are just some of the conditions and situations where pregnancy and breastfeeding can cause a few challenges and some medications that should be avoided. Like I said before earlier in the video, make sure to check out my other two videos that have pregnancy and breastfeeding featured in them. That's the guidance on prescribing video and my other topics video. And I hope you found this one useful. And if you did, why not give us a thumbs up, like, share, subscribe, check out my Facebook page, check out my Twitter page, and also my Instagram. And until next time, good luck with your revision and happy revising.